There we go. So you might get a pop-up that asks you if you want to stay on, even though this is being recorded. I'd appreciate it if you would. So anyway, my name is Greg Woods. I am the program coordinator for the Alzheimer's disease and related dementias program here at the Iowa Department of Public Health. And today I wanted to talk us through this program, which is meant to be an introduction for all things Alzheimer's, dementia, and a little bit about what we are doing at the Alzheimer's disease and related dementias program, or ADRD program for short. This program is meant to give you a broad overview of all things Alzheimer's and dementia and differentiate between the two, partially because we haven't always done a great job of doing just that. We also want to be able to answer your questions at the end of this program. So if you have any, feel free to type them into the chat at any point and we'll get to them at the end. If you're not sure how to get to the chat, if you hover over the top or bottom portion of your screen, depending on your view, you will see a little speech bubble, and that's where you can type things in. And again, we'll get to that at the end. There will also, over the course of this program, be a couple of questions that will test your knowledge or get your opinion about certain topics. So be mindful of that coming up. I'm going to turn off my video now just for bandwidth reasons, and we'll jump right into this. But I, again, thank you very much for being a part of this presentation. So as we begin today, this is a program that was developed in part through the Alzheimer's Association and the Center for Disease Control and Prevention, and also Emory University, Emory Centers for Training and Technical Assistance. It's been adapted so that it fits what we are doing here in Iowa specifically, and brings in some new data that we have on the landscape of Alzheimer's and dementia here in the state. By the end of the program today, what I'd like us to be able to do is provide a general description of dementia and Alzheimer's disease. The two are not exactly the same thing. We'll explain why in just a little bit. I want us also to understand where we have been in our understanding of dementia and memory loss, past and present. What worked years and years ago for our knowledge of Alzheimer's and dementia is very different in some cases than what it is now. Also, what are the risk factors for getting this disease? And what are the lifestyle choices that can affect risk, which I think is a really important topic that is thankfully being discussed and researched more frequently. Also, what is the current and projected scope of the epidemic that is Alzheimer's disease, not just here in Iowa, but across the US and across the world? Where is that headed? And what can we try to do to make a difference? Also, because of that scope, what's happening to the burden of these diseases on caregivers or on the workforce? And then that's where we can step in when it comes to public health. What can we do? What role can we play in addressing Alzheimer's, dementia, memory loss, and so on across the country and across, in our case, the state of Iowa? So let's begin broadly before we get too deep into this. What is dementia? Now, years ago, if you think about, maybe you heard people talking about this when you were young, or maybe your parents have talked about this. They used to figure that if you got old enough, you'd have what they called hardening of the arteries or senility. At the time, it was just considered a normal part of aging. And a lot of times since then, we have used the term dementia and Alzheimer's interchangeably, but that's not completely correct. Dementia is an umbrella term for a variety of conditions that affect the brain. It's a general term for decline in cognitive function, in other words. And specifically, we say severe enough to interfere with daily life. Now, that daily life part of that statement is the important bit, because that can get into some diagnostic criteria for what's considered just regular memory loss, what's considered MCI, which we'll talk about and define later, and what is dementia. But it doesn't just affect your memory, if you're thinking of it in terms of Alzheimer's disease. It also affects a person's ability to think, make judgments, social skills, and social abilities. And also, dementias are progressive, which means that if they affect just one of those areas, well, they're probably not going to only affect those areas over time. It's going to get worse. It's going to spread and affect others. So if dementia is an umbrella term for different types of brain diseases, well, where does Alzheimer's fall in that? Alzheimer's is the most common form of dementia. So if you want to look at this a different way, every case of Alzheimer's is a case of dementia, but not every case of dementia is necessarily Alzheimer's. Around 60 to 80% of all cases of dementia end up being Alzheimer's, but there are plenty of other types as well. You can get frontotemporal dementia, Lewy body dementia. You can get vascular dementia. There are mixed dementias. There's even pseudo-dementias, all these little subsets as well. It just goes on and on and on. There's so many different types under that umbrella of dementia. But if we're talking about Alzheimer's disease, usually the first thing people think of as a symptom is memory loss. And that's partially because the very first part of the brain that is affected in Alzheimer's disease is the memory center of the brain, known as the hippocampus. You can see it down along these bottom inner folds of the brain. So in this picture, just to orient you, this is essentially a slice of a brain that is looking directly at you, and they've taken a slice directly through the middle of it. And what you see on the left is a normal, healthy brain. You see all the rounded peaks and valleys and the thin wrinkles that go around it. You see these small little spaces in the middle. You see this supple area down here by the hippocampus on the bottom. And when you compare that to the brain on the right, that is an Alzheimer's affected brain. And in real life, that is actually very similar to what it looks like in terms of its volume and its general shape. You notice there's less brain there. The spaces inside that were really small have poofed up in kind of a vain attempt to keep the brain occupying about the same amount of space inside of the skull. But there's just less brain material, and those peaks and valleys are now big gorges that stick way down. And the area where our memories are held has just been decimated. This is why we see some of the changes that we do in Alzheimer's disease, why the memory is affected first, but why other functions are as well as the disease progresses. In fact, some of these changes in the brain are believed to start occurring, in some cases, 20 years before the onset of symptoms. Now, that's huge. We'll come back to that in the research section, but 20 years where there are brain changes that theoretically could be detectable, but you don't have any outward symptoms. That's a crucial area where perhaps we could step in and make a difference. So if we want to go back in time, now that we've defined what is Alzheimer's and what is dementia, let's go back to the beginning of Alzheimer's disease. And I guess I don't mean literally the disease itself, because that goes back a long, long way in time. But perhaps the first step might be to consider what is considered elderly. Now, I teased this just a bit ago, but for many, many years, the belief was that if you lived long enough, well, you were going to lose your mind. You were going to get senile. You were going to have that hardening of the arteries. You were going to have to be put away somewhere. And that was just a part of life. But that hasn't really been correct. And that certainly isn't correct from a scientific standpoint nowadays. But just imagine, if you will, in the late 1800s or early 1900s, that was the prevailing thought, that what we consider dementia now is just part of getting old. Well, enter this fellow. Any ideas who he is? That is Dr. Alois Alzheimer. He was a physician in Germany in the late 1800s and early 1900s. And he is, logically, where the story of Alzheimer's disease, as we know it, begins. He saw a patient who was exhibiting the signs and symptoms of being an old person when it comes to memory loss. Except the problem was, she wasn't old. So this made him wonder what was happening in this case. The patient's name was August Dieter, and he saw her in the early 1900s. And after she died, which was a very short time later, he received some slices of her brain to look at under a microscope. And what he found was that there were abnormal clumps of protein, both inside of brain cells and around them. Now, what clued him into all of this, of course, was the fact that we had somebody who was exhibiting the signs and symptoms of being old, but she was in her 40s and 50s. So that made him believe that perhaps these changes that we see in some subsets of the elderly were not actually due just to normal aging, but a distinct process that could be identified in the brain. And in this case, it was happening to someone who was young. Now, this was a fairly novel idea, and it started to take off. It was a few years later before they started calling it Alzheimer's disease at the behest of one of his peers and colleagues. But that was kind of where things stayed for a while, partly because we didn't have great ways to image the brain back then. There were a few different types of stains that you could put into tissue and look at them under a microscope, as he had done. But that was about as far as the research went for a while. Now, some of the changes that he saw were the same sort of changes that we see and that we identify as hallmarks of Alzheimer's disease to this day. If you look on the left here, this is a stylized illustration of what Dr. Alzheimer saw. So these kind of diamond pyramidal shaped objects are meant to be brain cells, which I usually think of as almost being like a tree in some ways. So outside of the cell body, you have branches, you have roots that stick out, and they're all intertwined with other brain cells, roots and branches, for lack of technical terms, axons and dendrites. And what happens is thoughts move through these brain cells as electrical and chemical signals, kind of like when you would have to call a long distance number way back years ago, they'd have to route you from switchboard to switchboard to switchboard to get you out there. That's exactly the way that thoughts move through the brain, from brain cell to brain cell to brain cell. But what he noticed was that some of the brain cells didn't really look that healthy. Some of them had clumps and tangles inside of them. And between the brain cells, there were these big aggregations, these huge clumps of plaques. Now we know of these as amyloid and tau, the amyloid being the clumps that sit between the cells and the tau being the tangles that are inside of them. And what ends up happening when he saw these two hallmarks is there's also accompanying cell death, because these cells are almost like little living things in and of themselves. They've got organs just like we do. And when those things get clogged up inside, it's almost like throwing an extension cord into a running engine of a car. It just seizes everything up, and it's not going to have a good time. So in this case, the brain cells died off. And since the brain is made of brain cells, that's where the shrinkage in the overall size of the brain came from. So as we look at our current understanding of not just Alzheimer's disease, but of aging, we have shifted our understanding just a bit. What we know right now is that as we age, our brain is going to age as well. It's not something that people often think about, even though we all just kind of accept that as we get older, well, maybe we're going to have a few more gray hairs, or our skin's going to get some wrinkles, or our back might hurt, or our knees. We just accept those as parts of our body that age, but we often don't include our brain in that conversation. But it ages as well. Now, some of those benefits can be good, like increases in wisdom or expertise or experience. But some of them can be detrimental, like the speed of processing, of making decisions. Sometimes it may take the brain just a bit longer to recall something that you used to be able to get in an instant. That happens. And most importantly, these types of changes are normal. It's okay that you may forget things occasionally, or that you may set something down and go, wait a minute, what did I do with that? Or hang on, is it Tuesday or is it Wednesday? That happens. That is normal aging. Now, where it begins to differ is something that we call, and I referenced earlier, MCI, which is mild cognitive impairment. This kind of represents an in-between stage of people who are aging normally and then people who are in dementia. So it's kind of sitting in between those, where there's still some difficulty with thinking. And the memory loss or the concerns of thinking are severe enough that you notice them. But it may not be every single day. It may not be severe enough to interfere with daily life, but you still get the occasional really odd lapse of memory. Maybe it's something that you've never had an issue knowing how to do or remembering before, and suddenly you do. This is often a diagnosable stage. And what it means varies from person to person. Some people go through MCI and that's it. They'll be an MCI for the rest of their lives. But some will go onward and progress to Alzheimer's or another form of dementia. Regardless, everybody who is in MCI is at an increased risk for that to happen, but it's not a guarantee. And vice versa, everybody that has made it to Alzheimer's or dementia will have passed through mild cognitive impairment at some point. Now, there are many causes to this, and sometimes it can be caused by external things like depression or a vitamin deficiency. Regardless, because everybody who made it to Alzheimer's went through MCI at some point, this represents another key part of our lives when perhaps we could step in and have some sort of intervention sometime down the road that could perhaps prevent people from progressing on to Alzheimer's. At this point, though, it represents a really important area of research. So what we know about Alzheimer's? Well, we know that it starts in the memory center. We know that it is a subset of dementia. We know that it's progressive, as we've talked about. What does that mean for a time period or how long that will go? Well, on average, we see 7 years from a person's onset of Alzheimer's disease to death. But that number, I think, is always very misleading in some ways because Alzheimer's is so very different from person to person. You have some people that progress extremely quickly, and then you have others that are in Alzheimer's, maybe not progressing very fast, for 20 years or more. So that 7 years really is just a statistical average. It's not so much a practical average because everybody varies from person to person. Now, you can also have what is called younger onset. Maybe you're kind of putting the pieces together here because you're hearing me talk about how it is usually associated with older people, but that August Dieter patient who Dr. Alzheimer saw was younger. Well, how can that be? There is a subset of Alzheimer's that is called younger onset that tends to affect people younger than the age of 65. It's very rare. Out of the 5.8 million cases of Alzheimer's here in the US, I think it accounts for somewhere between 200 and 300,000 cases. So it is a very small percentage, but here's another really important focus of research so that hopefully we can try to figure out what is different in younger onset and how can we relate that back to older onset or regular onset Alzheimer's disease. Now, of course, you also get other complications and rarities and things that tie in. We're learning more about this all the time, whether it be the effects of traumatic brain injury or PTSD on dementia-like symptoms, or chronic traumatic encephalopathy, which we hear about with football players right now. You know, the repeated blows to the head leading to changes in the brain. Parkinson's dementia. There's all these different complications or similarities that we see. And I'd love to, that's really a whole program in and of itself. I'd love to go into all that detail, but we just don't have the time for it right now. But overall, one main overarching theme about all of these changes related to Alzheimer's disease is that they are not a normal part of aging. I'm going to say that again. They're not a normal part of aging. Just because you live a long life does not guarantee that you will get Alzheimer's disease. So what does? Currently, we can identify a variety of risk factors that play a part in a person's risk for Alzheimer's. The number one of which is age. Yes, I've just talked about younger onset, but age is the greatest risk factor. The older one gets, the higher one's risk is for Alzheimer's, such that past the age of 65, every 5 years, a person's risk doubles. Every 5 years, it doubles. And if you kind of quick do the math, by the time you're getting into the 80s, you're seeing around 1 in 3 seniors that have some touch of this disease. The next biggest risk factor is our genetics, the genes that we receive from our family. Now, there are a few extremely rare cases of almost 100% transfer from one generation to the next, but it's extremely unusual. Overall, though, what we know is that the more close relatives that you have in your family who have Alzheimer's disease, the higher your risk will be later on in life. But again, to underscore, that's not a guarantee. A person's genes come from your mother and father. You really can't control that. Your age, no matter how much we try, we can't control that either. And unfortunately, those are the top two risk factors. But what we can control comes in that third bullet: lifestyle factors, choices that we make to live a healthy life or not. We'll talk more about these in detail in just a moment, but the lifestyle factors and the research surrounding them have really come to the forefront lately, because now we have quantifiable data to show that if you make the right choices in just a few areas of your life, you could see a big reduction in your risk for getting Alzheimer's later. Also, another thing that you're getting brownie points just by tuning in here is education is a powerful tool as well. So sitting down and listening to something and learning has actually been shown by research to decrease your risk. So all of you who are out there and paying attention right now, thank you. You're doing well. And there's plenty of other things that play into risk too, from environment to years of work to perhaps research into how many children a person has. It goes on and on and on. And it's a complex picture that we are still learning about. But one of the big ones that has also become a focus lately is the difference between men and women. Something so simple as that. But we know that 2/3 of all people who have Alzheimer's disease are women. And if you look at how that compares to men at certain ages, once you get over the age of 70, 16% of women have it versus just 11% of men. After age 65, in general, women tend to have a 1 in 5 chance of developing the disease versus 1 in 11 for men at the age of 65. Now, there's many things that this could be attributed to, and researchers are still trying to understand why this is. It is perhaps partially explained by the fact that women tend to live longer. At least that was the early line of thinking. The average age difference for lifespan here in the US is a couple years different for women and men. But even if we control that, we still see differences elsewhere. At birth, in fact, every 1 in 11 men will develop Alzheimer's in their lifetime. For women, that number is 1 in 9. So even at birth, there is a difference. And we're trying to understand why that is. Another area that we have noticed disparity comes between different races. African Americans and Hispanics, for instance, have higher rates of dementia than whites do. African Americans are 2 times more likely to develop Alzheimer's disease than Caucasians. Hispanics are 1.5 times more likely. Now, this is worrying in and of itself. And it's doubly so when you realize that historically, these groups have not been considered in research going back decades. The tide is changing now a bit, but many of the researchers nowadays are admitting, well, frankly, a lot of the work that was done many years ago only focused on white males. So you can begin to appreciate some of the disparities in even the research data that's out there, because here you've got 2 populations that are disproportionately affected but are least studied: women and non-whites. Now, this is maybe even triply worrisome when you realize that these are also, especially here in Iowa, relatively underserved populations that are often less likely to receive a diagnosis, or if they do get the diagnosis, it doesn't occur until later on in the disease when it's more progressed. And that requires more medical care, more costs, and lesser quality of life. So what are things that we can do to try to take control of our risk, regardless of where you fall in all of the risk factors that we talked about? Well, unsurprisingly, two of the big ones are diet and exercise. I know, earth-shattering, right? So diet is a big one, though, because if you think about what our brain does, it controls everything we do. So all of the things that we think and do and say come from our brain, and it's always working. The whole myth about 10% of your brain, that's not true at all. Your brain is constantly working thoroughly. So it needs nutrients, and it gets those nutrients through what we eat. It receives those nutrients through what we eat, through being pumped in the blood up to our brain. So exercise plays a big part too in keeping your heart and body healthy. We'll talk more about these in just a second. Staying social is another big one that we've learned about. When it comes to seeing other people, I know that's easier said than done nowadays with COVID, but staying social in any way that you can make a big difference as well, research has found. There are a lot of other factors that play into this too, though. Sleep and stress management are two huge ones that are often also easier said than done. So let's break this down a bit more. Looking just at heart health. So important here, because what is good for the heart is going to be good for the brain. If you want to think about that even more broadly, what is good for the body is good for the brain too. So when we talk about keeping your brain and your heart healthy, well, this could be anything from something simple as parking your car a little farther away from your building and walking those extra steps, taking the stairs instead of the elevator. It doesn't have to be running a marathon. It doesn't have to be anything super crazy to start off with. Same thing when it comes to diet. These diets are some of the most studied elements of lifestyle that we have in the last few decades. The DASH diet is a big one, which is the diet for high blood pressure. The Mediterranean diet, the MIND diet, that incorporate these different food groups in different proportions and things. That's been studied ad nauseum, and we find that there is a big benefit. Another big one is stopping smoking. Something so simple as smoking or not can drastically change the course of your life and your health. And people that stop smoking often find that in a very short amount of time, their lung capacity is increasing. Their lungs are trying to heal themselves. They're getting better oxygen transfer into the blood, which helps our brain. So something simple here. We're not asking you to, run that marathon metaphorically. We're asking you to take some steps, small ones here and there, that can make a difference down the road. It's never too early or too late to start. Another one that I get asked about a lot, outside of physical stuff necessarily, is mental activity. People say, well, if I do Sudoku or if I do all these other things, is that helping my brain? And my answer to them is, if you have to think about it. So things that challenge your brain are going to be more beneficial than the things that you can do second nature that you really don't have to think about. So this could be pushing yourself to learn new information, new skills, getting out and volunteering in something maybe that you've always wanted to do, but you never really have, and you're open to trying it. If it's reading, perhaps it's reading a different author, a different writing style. If it's games, well, try something that you don't know inside and out. If you're able to play solitaire or Sudoku and you're also watching TV or you're listening to something on the radio, that game is probably not pushing your brain like you're exercising a muscle. So go out of its comfort zone. And if you can do it socially, maybe down the road when things are clearing up a bit, then do that, because you're going to have added benefit from being social as well. So now that we know a bit of the disease and a bit of the risk factors, we can focus our attention into how widespread is this? Why are we talking about this? Why is it an issue? So that's where I'm going to bring your knowledge in. So we're going to open up a poll here, and this is going to be a true or false question. So feel free to answer. True or false, Alzheimer's is one of the top 10 leading causes of death in the United States. A lot of causes of death out there. but is Alzheimer's one of them? So we'll give that just a second here. And thankfully, overwhelmingly, 100% of you said that is true, and you are correct. Perhaps I should say, unfortunately, correct. You know, if you go back 100 years, all of the top 10 causes of death were infectious diseases. But as we have developed medicines and vaccines for them, nearly all of the top 10 causes of death right now, COVID aside, are chronic conditions. So when we look at where Alzheimer's falls over the course of this, it is the 6th leading cause of death in the United States, again, COVID aside, and it is the 5th leading cause of death among adults who are over the age of 65. I touched on this a little earlier. 5.8 million adults have Alzheimer's here in the US. 2/3 of them are women. And if you want to look at where we stand in Iowa, well, the trends are very similar in that way too. It tends to be over the age of 65, and it really ramps up after the age of 80. What that works out to is some 66,000 adults have Alzheimer's here in Iowa. And I'm always very careful when I say that, or at least I try to be, because you'll hear a lot of people say, well, there's 66,000 people affected by Alzheimer's here in Iowa. I don't think that's entirely true. The 66,000 is just those who are diagnosed. But when you think about caregivers and family and friends, the total number who are affected by this disease goes way up. And we see this in looking at our access across the state as well. Think of how rural Iowa is. And yet just 38% of primary care physicians, that's PCPs here, primary care physicians are in rural areas. We do have some memory care clinics here in the state, but there's only 6 of them, and they're nearly all in urban areas. That is the lowest of all of the surrounding states, all of our neighbors. In general, when you look at the total number of people per doctor, per family medicine physician, that's about 1,200 Iowans to 1 physician. That's just for family medicine. When you break that down into the specialties that serve Alzheimer's specifically, that's over 5,000 to 1 for neurologists here in the state. And it's over 15,000 to 1 for geriatricians. We'll talk about why this is in just a bit, but this is quite concerning. And unfortunately, it's growing. As we get closer to 2050, which I know seems a long ways away, but it's going to be here pretty soon, the US population above the age of 65 alone is going to be over 88 million people. And that 5.8 million with Alzheimer's that we have now is going to be nearly 14 million by 2050, a 3-fold increase. If you want to quantify this a different way, right now in the US, there is a new case of Alzheimer's every 65 seconds. Just a few years ago, it was 68 seconds. Now it's 65. And by 2050, it's every 33 seconds. There's going to be a new case of Alzheimer's. As you can imagine, this has quite an impact, not just in the total numbers, but functionally, this has a major impact. Let's start financially, for instance. As it is right now, with our 5.8 million, Alzheimer's is the most expensive disease in the United States. Just direct care costs alone exceed $290 billion. But the total annual cost, annual per year, is over 1 trillion. That's nearly 600 billion to Medicare, out-of-pocket costs of almost 200 billion. And you can see over 300% increase just in the last few years. These numbers are going up, and they're not exactly sustainable. Let's look at this a different way with another test your knowledge here on the impact of this disease. I mentioned geriatricians and neurologists and primary care physicians that are out there. But what percentage of Alzheimer's disease and related dementias care is provided by unpaid caregivers? And I'm talking family or friends or neighbors, people that this is not their job. They just have to do it in addition to everything. Is it 23%, 43%, 63%, or 83%? The percentage of Alzheimer's care provided by unpaid caregivers here in the US. Numbers still coming in. All right, wrapping it up in 3, 2, 1. All right, so it looks like we have 56% that say it is 63% and 44% say that it's 83. So what I'm seeing is people are thinking it's on the higher end of that spectrum. And unfortunately here, you are right as well. It is on the higher end, but it's on the high end of that. Those of you who said 83%, you're correct. 83% of care is provided by family members, friends, or other unpaid caregivers. Combined, that 83% gave over 18.5 billion hours of unpaid care that's valued at over $250 billion. That is just staggering. Another perhaps misconception is that 70% of people with Alzheimer's disease are actually still living in the community. A lot of people may think, well, maybe they just get shipped off, or families are quick to put them in care facilities or elsewhere. That's not the case. That 5.8 million Americans have over 16 million caregivers, unpaid caregivers here in the US. So of those 16 million, what did they look like? Well, perhaps unsurprisingly here, they too tend to be mostly women. 2/3, usually a daughter or a wife, are women caregivers. Over half of them are still employed. 86% have spent at least 1 year as a caregiver, but over half of all of those 16 million have been at it for 4 or more years. Remember, we said that the average from diagnosis to death is 7 years, but that's really only a statistic. A lot of times caregivers are at this job for a long period of time. This carries a multitude of challenges, both physical, psychological, social, financial, on and on. It's led to the caregivers themselves having loads of additional healthcare costs, emotional stress affecting 60% of them at a rate of high or very high. 3 or 4 out of every 10 suffer from depression, at least. And there's also an increased likelihood that their health will deteriorate along with the person for whom they are caring. Now, this is, I think, an important area to step in and say that if you are in this situation yourself, you know these experiences very well. You felt all of this. And especially on that last bit of the worsening health problems. I know I'm just a random person on the internet at IDPH, but for what it's worth, I'd like to give you permission, if you're a caregiver, to take even just a brief amount of time to take care of yourself. That is so important. As a caregiver, we're trying to provide the best care that we can. And if we can't be as healthy as possible, if we can't do the things that we need to do for ourselves, the care that we provide is going to suffer too. That's just my brief aside here. So anyway, I mentioned that quite a few of these caregivers are still at work. Maybe you're an employer and you're wondering, oh, is that some of my people as well? Odds are yes. The statistics show that over half of all caregivers have had to go in late or leave early or take time off to be a caregiver. Nearly 20% went from working full-time to part-time to try to accommodate. 16% took an extended leave of absence, maybe for a long stretch where they're just hoping to catch up and help their loved one for a little bit. Almost 10% have turned down a promotion because they worry about what that's going to do for their availability to be a caregiver. And 1 in 6 have left work entirely to try to help a loved one. It speaks at caregivers' altruism. It speaks at their hearts. It speaks to their struggle of what they go through. On the flip side of this, it's not just the unpaid caregivers who are facing sometimes an uphill battle. Health professionals as well are seeing a big shortage of professionals, which leads to a much bigger influx, the inability to see as many patients as they could, and not keeping up with the trends of growth that we see in this disease. If we want to keep pace with what Alzheimer's is doing in our population, we would need another 3.5 million healthcare professionals just by 2030 to try to keep up, fill that gap. We have just half of the number of geriatricians that we need. Fewer than 1% of nurses and physician's assistants and pharmacists identify specifically as geriatric specialists. And other healthcare professionals, even if they do work with Alzheimer's, are often not adequately trained for Alzheimer's and dementia. If we want to hone in a bit more specifically on direct care workers, we see it here too. We see a huge increase in the number of workers that we need as the population ages. And this is hitting Iowa especially because we have so many small towns and so many rural areas that have to converge on the next biggest town around them that sometimes doesn't have the resources or capabilities that it needs. If you've ever worked as a CNA or a direct care worker, you'll know recruitment and retention is difficult. There's a lot of turnover. The hours can sometimes be crazy. And this is all on top of a job that is extremely challenging. And on top of all of this, when schedules are already strung thin, we have to try to get additional training in there. And that can lead to some difficulties too. All of this doesn't paint the most ideal picture, I realize. But that is where we are trying to turn the tides. That is where public health can try to step in and start to put an emphasis on Alzheimer's. If you go back far enough, and really you don't have to go far at all, I'll just tell you, this wasn't always viewed as a public health issue, surprisingly. Alzheimer's was seen more as, well, it's an aging issue, or it's a medical issue, it's a mental health issue. Even though this is a disease that affects a huge percentage of the population. And again, I'll say I use the word affects there. I'm not just talking about diagnosed. There's impact everywhere. And for a disease that is multifaceted, we need an approach that is multifaceted as well. Just 4 broad ways that public health can make a difference in this is, first off, surveillance and monitoring, figuring out how broad is this disease impact. We've done that here at IDPH by getting a landscape assessment put together that just looks at dementia resources and impact here in the state. But there's many other ways to try to quantify this too. Also, we need to work on risk reduction, messaging, getting people aware of what's happening and what they can do to change that. We also need to put a big emphasis on early detection and diagnosis. And this can be from a variety of standpoints and areas of public health, whether it's oral health or domestic violence prevention or breast cancer screenings or any other number of things. The more we can get the word out and the more we can get people to go talk to their doctor early before this progressive disease gets worse, that's where we're going to have an impact. And then also from a workforce standpoint, if we can assure safety and quality of care for the actual people who are working day to day with these loved ones, that's going to make a big difference too. Early detection is a huge one, in part because people want to know. And yet, this is kind of a quandary that I've had working through this position, is that most people say, yes, I would want to know if I'm going to get Alzheimer's disease, or nearly everybody, 97% would want to know if a family member was going to get it. However, just 1 in 4 Iowans actually use their free wellness visit that's provided, again, free by Medicare, to go in and get a cognitive screening, to get things checked out. And we also see from something like the Alzheimer's Association's Facts and Figures document that most people believe that if it's important, their doctor will bring it up for them. And on the flip side of that, we hear from doctors that say, well, if this is a concern of my patient, they'll let me know. Think about that. You've got two people who say the other is going to bring it up first. And then what often happens is neither do. So we want to encourage that and change the tide. Thankfully, we are seeing importance put on Alzheimer's disease. Healthy People, which is a document that's put out targeting every 10 years. So we're right now in Healthy People 2020, finishing up. We're looking now to Healthy People 2030 is the name of the document. They have proposed objectives for Alzheimer's disease in many of the same areas that we just talked about. Our program here at IDPH is existing now. So we are trying to let you know that the state and that Iowa Department of Public Health emphasizes Alzheimer's disease as well. We see projects like dementia-friendly communities popping up, especially over in Eastern Iowa, where they are looking at a holistic approach to a community preparation to handle people with Alzheimer's disease, to make sure that they are comfortable, that they have access, that they are respected, that they're supported, and that people who are involved in any way with seniors or dementia can be trained, can be prepared. Here at IDPH, we are also working in partnership with the Centers for Disease Control and Prevention. As a part of the BOLD Infrastructure Act, which is building our largest dementia infrastructure, we're working on compiling resources from around the state so that we can be a go-to for you to come to and say, here's what I need, where should I go for it? We finished that landscape assessment, and right now we're working on fostering partnerships and building a coalition that can help us to design and publish a state plan that is specific for Alzheimer's disease. We want to increase messaging and awareness. We want to decrease those preventable hospitalizations that if we only would have caught this disease earlier, we could have handled it. And we also want to increase the number of people who talk to their doctor. And hopefully this leads to better data collection as well. Now, all of this is in collaboration with the Healthy Brain Initiative's roadmap. Their 4 areas that they put out are educate and empower people, develop and mobilize partnerships if there's already existing resources out there. They want us to assure a competent workforce, and they want us to be able to monitor and evaluate what's happening. The good thing is, you can get involved with this. If you're interested in being on this coalition, if you have experiences or knowledge in Alzheimer's, dementia, or seniors, or anything like that, reach out to us and let us know. And in turn, we are also trying to have resources out there as well. One way that we are doing that is we now have a website, and there's a lot on there. And my colleague, Katie Fodenhauer, has done a great job of filling that out and making sure that there's plenty out there for you. So Katie, I don't know if you are able to come in and chat. She just put the link to our website in the chat, but Katie, if you'd like to walk them through some of these resources, that'd be great. I will need to come in and find her. Just a second here. All right, there we go.
Thank you, Greg. As Greg mentioned, we have started a collection of resources on Alzheimer's, dementia, and caregiving, and most of these resources live on the website, which I have just popped in the chat box for you there. We have fact sheets around Alzheimer's and dementia and caregiving, warning sign resources, healthy brain and caregiving resources, as well as a variety of infographics. We also house a Saving Your Brain quiz, where people who take the quiz can see how well they are currently doing in reducing their risk of cognitive decline. And the quiz also helps you determine what lifestyle changes you can incorporate to reduce your risk. So if you haven't already, I highly suggest checking out that quiz and finding out more about how you can reduce your risk of cognitive decline. Our main messaging focuses during the first year of this program have been around raising awareness about Alzheimer's and dementia and encouraging Iowans to discuss any memory loss symptoms with their healthcare provider. Another focus has been the connection between cognitive decline and chronic disease. And as Greg mentioned, sharing things we can do in our lifestyle to lower our risk of cognitive decline. If you follow IDPH on social media, You may have seen a few of these messages over the last few months, and feel free to keep following us there. But we are offering now monthly social media sets to be emailed out to Iowa organizations to share about Alzheimer's and dementia risk reduction. So if that's something of interest to you, please reach out to Greg and we can get you on our distribution list. We also have RAC cards available that are focused on the connection between healthy brain and physical activity, nutrition, hypertension, and diabetes. And we'll be printing those soon. So again, if that's something that's of interest to you, just let us know and we're happy to send those out at no charge. And again, just encourage you to visit our website and check out our resources and let us know if you're interested in any of them. And I'll pass it back to you, Greg.
Thank you very much, Katie. We're going to have a slide with just a few of those resources here in just a moment. But first, what I'd like to do is one last poll question for you. And this is to see how we are doing with this education program. It's fairly early and we're still developing it, but I want to put this out there and see how much you agree or disagree with this statement. This program helped increase my knowledge of Alzheimer's and related dementias. So feel free to pop in where you think you fall on that set. And as Katie was saying, in terms of our website and other things that are on there, we are tied in the Bold Grant with a few different partners. One of them is a center of excellence as well. That's the Alzheimer's Association. So we do have information about them on this final slide, as well as where you can go into the CDC's website and look at the overview of this whole program on Alzheimer's and healthy aging. So be sure to check that out specifically as well. Also a reminder here, in just a moment, we'll get to questions. So just have a couple more needing to put in their answers. I think we are good. So thank you very much for that. So if you want to get involved, you can reach out to me. Here is my email directly. Again, in the chat, Katie put the link to our webpage at IDPH. You can reach out to either one of us. Katie put her email in there as well. She is, she neglected to mention, the education coordinator for this project. So we are both working on this. And now I will turn it over for any questions that any of you have. This could be about Alzheimer's specifically, about research, about anything that you've heard with the disease. Feel free to shout it out. So looking into the chat, I will take a peek in there. We had a question a little earlier on about if there's research with Native Americans. So this is, I was talking earlier about all the different subsets of populations that haven't been well represented in research over time. And Native Americans are one of those. We see that in Canada as well with their First Nations, where we are learning that based on a variety of risk factors, that they too are at a higher risk for developing Alzheimer's disease than Caucasians are. Now, there's several different facets to this. One of the broad ones is in all of these populations, each one has slightly different risk factors for chronic conditions that affect them. But broadly overall, chronic conditions increase a person's risk for Alzheimer's disease. And that is on top of, without saying, all of the different socioeconomic factors that play into this as well. And of course, there's access, and of course, there's medical trust issues, and there's all these different things that different populations have. And certainly when it comes to underserved populations and Native Americans included in that, they are an at-risk population that we need to do more with. And there are certain groups that are working, I know here in the state, for some of our tribal ones. There's also ASTHO, which is the Association for State and Tribal Health Officers. They are working on these sorts of things. They have some really good stuff on different resources that are out there that people can use to connect with this. But yeah, there's definitely work to be done, but they are at an increased risk, and there's a few specific bits of research that go into that. But yeah, hopefully that helps to answer that. Any other questions that people have? Feel free to type them into the chat. And I'll say that if you are working on that, since we're coming up to the top of the hour here, if you think of any questions also that you would like to ask afterward, feel free to send them in an email. Feel free to send them my way, and we can get those answered for you. Again, whether it's about the disease or about research specifically, or about our project, or you want to get involved, whatever it might be. If we don't have any more questions that are coming through, I will say thank you so much for tuning into this. Hopefully this gave you a starting point. We are also always looking for groups that may be interested in viewing this presentation. So this is being recorded, but we would love to be able to cater it and tailor it specifically for whatever group you may think it would be beneficial to show. So feel free to let us know something about that as well. Thank you so much. You'll be hearing from this program, certainly more in the future with the Alzheimer's disease and related dementias program here at IDPH. And we're excited to continue to serve all Iowans who are affected by this disease. And if you need those resources and you haven't gotten them yet, or you're maybe wondering what the first step should be, reach out to any number of those. Please, you are not alone in this. That is a number one message that I want to get if you're going through this. You are not alone. Take that with you. Best of luck, and thank you so much for tuning in. Take care, everyone.